Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, my incredible and knowledgeable nurse practitioner, Rosalind Arp, and I share our combined 30 years experience to guide both men and women as they age. Listen as we dive into a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. These real-life insights are always rooted in solid scientific knowledge. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Welcome to the podcast. Today, we are talking about one of my favorite subjects to educate women on, and that is estrogen and the risk of breast cancer.
Breast cancer is the number one reason most of my patients does not want to start hormone replacement therapy, and we have to educate our patients regarding the breast cancer risk associated with hormone replacement therapy, which is essentially none. And I know, Dr. Jackson, this subject is close to your heart. You want to tell us about your story first?
Yes, my family history is very strong for breast cancer. I had a maternal grandmom who was diagnosed with stage 4 breast cancer. My mom and my aunt, they are both her daughters, were each diagnosed with breast cancer. So it's pretty prevalent in my family. So obviously it's something that I want to make sure that I know for me personally what the actual risk of breast cancer is in women using hormone replacement therapy. And hopefully once we finish the podcast, people will understand much more confidently what the risk is, if any, in using hormones and breast cancer.
What I tell my patients is breast cancer is the most common cancer diagnosed in women. When 1 out of 6 women can get breast cancer in their lifetime, and your risk increases as you age past the age of 50. It's not related to genetics as much as environmental. Regardless of if you choose hormone replacement therapy or not, yearly mammogram screening is recommended for all patients. According to ACOG, which is the American College of Obstetrics and Gynecology, the current screening guidelines for breast cancer are that women should begin their screening mammograms at age 40 or at 10 years younger than the youngest relative in your family who had breast cancer. So for example, if your mom had breast cancer at the age of 45, you should start screening at the age of 35, and you do yearly screening after that. And some women who are at higher risk for breast cancer based on their genetics or their family history may also qualify for screening with a breast MRI as well as their screening mammogram.
I think a lot of the fear of hormones equals breast cancer came after the 2002 publication of the WHI study. And this is one medical study that many women know by name. We really want to dive into what did the study show and what's happened since that study, because there's so much misinformation about it. And even to this day, there are still physicians who really overestimate the risks of hormone replacement therapy in women and under-recognize the benefits of hormone replacement therapy. So it was in 1997 when WHI started their study. They enrolled more than 20,000 women in the study. And we already knew at that time that hormone replacement therapy did a great job treating hot flashes and night sweats. Those are called vasomotor symptoms. So they didn't want to test for that. That had already been proven. What they really wanted to know is, can hormone replacement therapy reduce chronic diseases in older women, like heart disease and stroke risk and blood clot risk, things like that? So they intentionally chose older women who weren't having vasomotor symptoms to be a part of the study. And they had 3 distinct study groups that they looked at. The first group took oral estrogens and oral progestin. The second group took oral estrogens only. That was a group that had a hysterectomy, so they didn't need any progesterone to protect them. And the third group took placebo only. Before they started the study, they set out some goals, and they said, if we reach any of these limits on breast cancer or stroke or heart attack, we're going to close the study. So off they went with their study, and they had planned for it to be 8 years long. But after 5 years, the people in the first group, that was the oral estrogens and the oral progestin group, reached one of the criteria for breast cancer. So there was a slight uptick in that group in breast cancer. So they closed the study, and the headline the next day was, estrogen causes breast cancer.
So I know what the headline said because a lot of patients have stopped it, but what was the actual risk that the study showed?
So we have to look at the actual numbers of what the first group developed. And in that first group, the reason they stopped the study is that for every 10,000 women, 7 of them had a heart attack or an MI, 8 of them had a stroke, and 8 of them had breast cancer. So that's 8 out of every 10,000 women. In that same group, there were actually improvements in some health areas. In fact, there were 6 for every 10,000 women, less colon cancers, and 5 for every 10,000 women, less hip fractures. Unfortunately, all of this information didn't make it to the headline because the headline was estrogen increases your risk of breast cancer. Thousands and thousands of women immediately stopped their hormones and flooded their doctor's offices with calls and just had this huge fear. Even physicians were like, oh, I guess estrogen causes breast cancer and we can't prescribe that anymore. Despite this information, the second group in the study, which was the one taking oral estrogen only, continued on. They did not show any increased risk. So that arm of the study continued on for 2 more years. The problem is that the initial design of the WHI study had so many problems with it, so that these results that we're talking about are simply not generalizable to the whole population.
So, Dr. Jackson, you were a practicing physician when the WHI study came out.
I was actually a brand new practicing physician, just a month out from residency. And at that time, we still worked with paper charts. And within a week, I had stacks and stacks of charts on the floor all over my office of patients calling in fearful and wanting to know, do I stop my hormones, or I've already stopped my hormones, and what do I do now? So I was definitely a part of that first onslaught of fear generated by the WHI headline.
And were you fearful of hormone replacement therapy at that time, or when did you change your perspective of it?
At that time, when the headline came out, the study itself wasn't even published in medical journals. So this could probably be a totally different podcast, but they rushed the headline out so quickly that even some of the researchers involved in the WHI study were not aware that the headline was coming out. And the researchers in the WHI study said, wait a minute, that headline does not accurately reflect the information that we're seeing. That headline is inflammatory, but they were not consulted when the headline was created and sent out to the media. So even the researchers for the WHI were left scrambling when the headline broke. So for regular OBGYN physicians like me at that time, we had no resource. We couldn't even go to the study to look at the data ourselves. Within a couple of weeks, though, they finally got the study published. And my colleagues and I were able to look at the study and say, okay, we see this increase in risk, but we know the difference between the absolute risk and relative risk. And that was what was able to help me counsel my patients at that time when the headline broke.
So I actually saw something that said that it also increased invasive breast cancer risk by 26%. What did that mean?
This is one of the ways that the study gets blown out of proportion. While that 26% value is correct, you have to look at what the absolute risk is. The baseline risk of breast cancer in that population was about 2.3%. If you increase that by 26%, it now means the baseline risk is 2.9%. So for women taking hormones, both oral estrogen and oral progestin, they increased their breast cancer risk from 2.3% to 2.9%, according to this study. That doesn't sound like anything unless you tell someone, oh, that's a 26% increase in risk. And you think, oh my gosh, that's huge. So you can somewhat manipulate this result a little bit depending on how you look at the numbers. But I really want to focus on some of the flaws in the study, because now in the 20 plus years since WHI has been published, the study has been looked at over and over again, and the data has been dissected and reanalyzed. And unfortunately, with any medical study, it's garbage in, garbage out. If you start with poor information, you're going to get poor results. And this study had a lot of criticisms that I think patients need to understand.
I know one of the main criticisms is that they only use oral estrogen and oral progesterone. Can you tell us more about that?
Absolutely. At the time the study was done in 1997, the main hormone that dominated the market was oral Premarin. And oral Premarin is conjugated equine estrogens. This is a grouping of estrogens that is made from concentrated pregnant horse urine. So sometimes it's called horse estrogens. But these estrogens are not bioidentical. It's just that Wyeth, who is the company that makes Premarin, did an amazing marketing job and sort of flooded the market with oral Premarin tablets in a variety of doses. And that's what was used in the study. We now know that estrogens given orally are the only route that increases your risk of blood clots, like DVTs in your legs, or pulmonary emboli, which are PEs in your lungs. Non-oral routes of estrogen, like patches, creams, or hormone pellets, do not carry that same risk.
But you're saying that even that women that took Premarin oral tablets did not have an increased risk of breast cancer?
That's correct. So even in that second group, remember that was the group that had a hysterectomy, so they only needed the oral Premarin tablets. That group had their study continue on for 8 years and showed no increased risk of breast cancer. And the study did show, again, it's going to depend on how I tell you the number. The study did show a 37% increase in blood clots in the group taking oral estrogen. What that actually means is 4 more blood clots over the baseline. So again, 37% sounds like a huge increase, but the absolute number meant that there were 4 more blood clots that would not have occurred.
And that's out of the 10,000, correct?
Yes, that's correct.
So what is the hormone that is causing the breast cancer in that first group then?
So we now really understand that it was the synthetic progesterone that was being used in that first group. In addition to taking the oral Premarin, that first group was also taking medroxyprogesterone acetate. This is a lab-made progesterone. It looks chemically somewhat like the natural progesterone that comes from our ovary, but not completely like it. And even most breast cancer surgeons now recognize that it's the synthetic progestin that was responsible for the increased breast cancer risk in that first group.
So with the second group of the study, did they see any benefits at all or risks for breast cancer?
In the second group, taking only the oral Premarin, not only did they see, as I said, an expected amount or a slight increase in their blood clot risk, but they actually saw significant improvement in those women's health. They saw a 37% decrease in their cardiovascular disease, a 12% decrease in new diagnoses of diabetes, a 30% decrease in fracture risk from osteoporosis, and most importantly, an 18% reduction in breast cancer. So did you hear the headline about oral estrogens decreasing your risk of breast cancer?
Definitely not.
Yeah, I don't think that one hit the headlines. That's not as sexy as estrogen causes breast cancer. And that's even using oral estrogen, which most menopause providers now recognize it's probably the least safe way to provide estrogen to our patients.
So what do you currently recommend?
Instead of medroxyprogesterone for postmenopausal women, I think the best progesterone for them to use is a bioidentical progesterone like micronized progesterone. So let's go through a little bit about progesterones. Natural progesterone is made by the ovary, and there's only one type. Synthetic versions of progesterone are called progestins, and there are many types of those. Chemically, they're divided into 2 sets. Some progestins are chemically similar to progesterone, while others are chemically similar to testosterone. Natural progesterone works in a very protective way all over the body to balance the effects of estrogen. So in the uterine lining, estrogen makes the cells grow, whereas progesterone resists that growth and changes the cells into a secretory form. At the level of the breast, estrogen stimulates breast cells, whereas progesterone modulates that growth. Synthetic progestins do some of the things that natural progesterone does, for example, protect the uterus against endometrial cancer when you're taking estrogen. But unfortunately, they don't have all the protective and beneficial effects of natural progesterone, especially when we're talking about the breast. When I recommend micronized progesterone to patients, I know that they're getting a bioidentical progesterone, so chemically it looks exactly the same as what your natural ovary makes. Micronized means the particles are made very, very small, generally less than 50 microns, which allows the progesterone to be consistently absorbed by the GI tract when you take it as a capsule.
And another flaw of the WHI is the age of the women that were enrolled in the study. As you mentioned before, most of the women enrolled were in their 60s, 70s, and even 80s, rather than using women that are typically entering menopause in their late 40s and 50s. These women tend to be a lot healthier, but were underrepresented in the WHI sample.
That's right. I think this is one of the biggest flaws in the study, their patient population. So 70% of the women in the WHI study were over the age of 60. The average age was 63. And they did pick these women intentionally. As I said earlier, they weren't trying to treat vasomotor symptoms. So they chose these older women who were all finished with their vasomotor symptoms. But what's interesting is if you take the data from the WHI and you break it into two parts, how did the women between age 50 and 60 do in the three groups versus how did the women above age 60 do in the three groups? The results then suddenly become very, very different. If you look at the group of women who was between age 50 and 60, in both groups where women were taking hormones, we saw a decreased risk of cardiovascular disease and a decreased overall mortality. And I think this really speaks to the critical window of when women should start their hormone replacement. Women in their 50s and 60s are generally healthier than women in their 60s and beyond. So they have less heart disease, less diabetes. And I think this is what the study wanted to find. Do hormones help to prevent chronic disease in women? And we're starting to see that, yes, they do, if started early enough. But if you take a woman who is overweight, high blood pressure, high cholesterol, and then you try to give her hormone replacement therapy, it's not necessarily a treatment for those diseases. It's not going to reverse what's already there. But I think this study is telling us that it can help with prevention if you don't already have the disease.
And I think one of the main questions too is that because a lot of the women in those older population did not have estrogen to begin with, we wonder now how many could have been prevented as well, correct?
If many of those women in the study actually had started their hormone replacement therapy when they were in their late 40s or 50s, the results may have been very, very different. So it would be amazing if someone could repeat the WHI, correcting these flaws. So choosing women in the perimenopause and early menopause, using bioidentical non-oral estrogen and bioidentical progesterone, I think we would get drastically different results. And I would love to have that study, but I'm telling you, I don't think we're ever going to see it. The cost would be huge. People are still feeling fearful and stung about the results of the WHI, and nobody's really willing to put up all the money that it would take to do a very large-scale study like that. And this is where the real damage lies. I firmly believe that the WHI study was one of the most detrimental things ever to happen to women's health in the history of medicine, because so many women who could have benefited from proper hormone replacement therapy did not receive it. All of those women who were in the perimenopause or early menopause timeframe when the WHI came out were scared away from using proper hormone replacement therapy. Those women were then allowed to age without good hormones, significantly increasing their risk of chronic disease, increasing their risk of dying from a heart attack or stroke, and increasing their risk of dementia, as well as osteoporosis and all the fractures subsequent to that condition. I know that you have heard me say this before, but I really feel like we're in a dark age of medicine. And 100 or 200 years from now, people will look back at this time in medicine and say, I can't believe physicians allowed generations of women to die from fully preventable diseases simply by not properly maintaining hormone balance.
Yeah, I agree with that. Well, okay. So one of the main questions I usually hear as well is that my friend had breast cancer and now she's not allowed to take any type of hormones. So obviously there is some relation to that. And what I tell my patients is that there are certain types of breast cancer that are estrogen positive. And what that means is it's fed by estrogen. If you have an estrogen positive breast cancer, they do actually give you medications to block any type of estrogen to be produced by your body. And they do recommend you not to take any type of estrogen replacement therapy because if there is something left behind, you don't want to grow that cancer as well. But that doesn't mean that estrogen itself has caused the breast cancer.
That's right. And if you just look at some other big statistics, 80% of women who've been diagnosed with breast cancer have never used hormones in their lifetime. So just as a number, hormones are not the main contributor to breast cancer. Or if you look at it from a different point of view, what is really the risk of hormones increasing your risk of breast cancer? So the increased risk of breast cancer that the WHI showed is the same amount as the increased risk of breast cancer that women get from being obese, from drinking large amounts of alcohol, or from having an early first menstrual period. So, how many obese women do we know in the United States? How many do we know that drink alcohol? And all of that is increasing their risk of breast cancer to the same degree as what was shown in WHI. And in fact, the relative risk of breast cancer is even higher than what was found in WHI for things like having a pregnancy later in life or having dense breasts on your mammogram. So I think that helps to kind of put into perspective that we've completely inflated this risk of breast cancer found in the WHI. And women walking around with dense breasts or women who had a baby later in life have a higher relative risk of breast cancer than what we found in WHI. So I think the main summary is that we need to understand the flaws of the WHI and how to use it today. I would certainly hope that physicians who are not menopause specialists and not hormone specialists would at least defer to those who are, rather than adhering to those old thoughts of, well, you have to stop your hormones after a certain time, or your mom had breast cancer, therefore you can never take hormones in your lifetime. Those are such old and outdated dogmas.
Yeah, when I heard you going through that list of other things that can increase your risk of breast cancer, one thing I was struck by is that a lot of them you have control over. So patients have control over their weight, and they can reduce their weight, which will reduce the risk of breast cancer. Patients have the ability to stop smoking or decrease their alcohol intake to reduce their risk of breast cancer as well. So we call those modifiable risk factors, and patients have control over them. Some of the other factors we mentioned, unfortunately, are not modifiable, like having dense breasts or the age at which you had your first period or your first baby. We can't change those things. What is important for women to understand is that they do have control over some risk factors for breast cancer, and it's not all about hormones. And what we can infer from the WHI study is that by not replacing women's estrogen as they age, we're actually exposing them to all of these age-related diseases like heart disease, stroke, diabetes, and osteoporosis that can not only lower their quality of life, but increase their risk of death.
Right. By withholding estrogen from women, you're actually exposing them to additional risks from lack of estrogen, just like you mentioned. So it's a complicated area, I understand, but I definitely want our patients to feel empowered to find a hormone specialist to really get true information rather than just the headline information, which for most women is not enough to make an informed decision.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.